2001, a project called the Metro East Coast Project, which didn't quite reach Rhode Island, but was spearheaded by the Earth Institute at Columbia University, started to look at what we thought the climate impacts would be and subsequent effects from that. So the climate parameters first, and then the impacts. And they looked at multiple sectors, and this is a theme that you'll see in a couple of the projects that I'm going to highlight. So just to sort of let you know that this is going on actually more than a decade of work, people trying to look at using what we call downscaled models to make projections of what we think is going to happen, rather than what the IPCC, the Intergovernmental Panel on Climate Change, uses, which are global circulation models, which have sort of scales of effects on the 300 square kilometer grid size, versus these type of models which start to bring it down to more a county scale, which much more localized and relevant. Another example, this one I was directly involved in, this is a publication from just 2011, and public health was one of 8 sectors here. And we're focused on New York State. There hasn't been an equivalent to this scale done yet in Rhode Island. But I wanted to highlight it, not to focus on New York State, but to highlight the multiple sectors. And from my perspective, as a pediatrician, as a public health researcher, every one of these sectors is health relevant, because certainly water resources have direct health effects or indirect health effects. Obviously, if your telecommunication systems fail, then your health delivery care systems fail. So there's all of those sort of natural links to me. But inherently, a lot of this health work is multidisciplinary. So this is called the CliMaid project from New York State, and it was funded by NYSERDA, our Energy Research Development Authority. I'm going to focus on sort of 4 areas that I've chosen, some because I think they are most relevant in terms of U.S. health burden, and others that I think are more relevant to Rhode Island. First, for heat waves. You might or might not know that in terms of hazards, by and large, weather-related hazards, heat in the 30 years, roughly between the 70s and early 2000s, heat and drought accounted for about 20% of all hazard-related deaths. It's actually gotten worse since then, and the CDC claims, this is a little bit debatable, but certainly it's the biggest chunk of the pie even here. In this publication from this public health messaging publication from the CDC, they actually claim that extreme heat causes more deaths than any of those other hazards combined. And that has been the case. Heat has accounted for an increasingly larger proportion in the subsequent years since 2004. So this might lead you to ask, what is extreme heat anyway? How do you define that? And it's certainly defined locally. A heat wave in Atlanta is probably met, the criteria is met at a higher threshold than a heat wave in Newfoundland or somewhere farther north, even New York City. And it should be, from a public health perspective, the threshold for declaring a heat wave should be locally relevant. And that can change over time too, because we certainly know that more people are getting air conditioning an increasing prevalence now in New York City than they had 20 or 30 years ago. And so what threshold might result in population health effects is changing. It's a moving target. But by and large, 100 degrees is hot anywhere in the United States. And so I use that as an example here, even though the threshold for actual heat waves is lower in many parts of the states, to show you just some of what we've seen historically and then what we expect to see going forward. So this is, the color scale is the number of days over 100 degrees, and the pale yellow is less than 10 days, and the dark red is greater than 120 days of the year. And so you can see in a couple decades of the 60s and 70s, most of the country, except for some very southwestern areas, was in this lower range. And then under 2 different scenarios, low and high emission scenarios, we saw projected for the 2080s, 2090s, that would likely change. I wanted to give you some more recent data color scale is a little bit different here. This is just from 2011 and 2012. And you can see that, to me, I'll toggle back and forth just a minute, that it, in many ways, I think it already looks like the lower emission scenario of the 2080s in terms of where we're starting to see, at least in 2011, that higher density of extreme heat days. And this is consistent with what the trends are predicting. And so I'm not going to dwell on heat a lot, and I think that the points have already been made in comparing Boston to Rhode Island, for example, that urban areas are hotter. And that's sort of a fascinating phenomenon called the urban heat island effect. And basically, it means that urban areas compared to the surrounding suburban and rural areas can sometimes be 10 to 15 degrees hotter at the same time of day. And that's because of less vegetation, typically more heat-absorbing surfaces for a number of sort of geophysical properties that cause it to heat up more, or cause the temperature not to drop as much at night. So in the daytime, it starts out hotter to begin with. Just a final word before we move on from heat. Are two examples. One is from 1995 in Chicago, and the other one's from 2003 in Europe. Just by show of hands, who knows about those as major public health events? Okay, good. So half of you do. And whether or not you know about both or either one, they're both important. In Chicago, in the summer they had, of 1995, they had a heat wave, and the mortality toll from that was somewhere in the 300 to 500 range. It so overwhelmed the morgue that they had to commandeer the refrigerator trucks from Taste of Chicago, which was happening concurrently with that event, in order to store bodies. So it happened fast, and it quickly overwhelmed not the healthcare system, but the morgue system in that case. Hundreds of deaths sounds like a lot. What happened in Europe in 2003 makes that pale in comparison. And what's most fascinating about and tragic about that, to me, is the social phenomenon that underlay that. So in the summer of 2003, I was actually living in France. It was hot. In July, there was a heat wave, and there was not a significant morbidity and mortality rates from that. A little bit of upticks if you look at the death rate. But in August, there was a slightly more severe heat wave, and there was dramatic mortality, and the counts range in the tens of thousands. I've heard as high as 50,000 in Europe that occurred during that approximately 2-week heat wave. What happens in August in Europe? People go on vacation, right? Families go on vacation, leaving and sort of detaching typical social networks that exist to protect the most vulnerable during heat waves, which are people over 65. That's what the epidemiology shows. And so in general, we think that what we witnessed was a social phenomenon, because compared to July, when there wasn't such a public health toll, it was really impressive. So so just another example of, in that case, a big health burden from heat. And moving on to flooding, we've heard lots about water and shorelines, and so I'm just going to give a couple other angles, not to focus so much on sea level rise, even though that's probably one of the most relevant in terms of climate change for Rhode Island. This is a third project. I mentioned the Metro East Coast. I mentioned the Climate project in New York, and this one actually does span the area of Rhode Island, but it focuses on 3 major urban centers: Boston, New York, and Philly. So this CC run, as it's nicknamed, is looking again in sort of a multi-sector approach at climate risks and expected impacts, and ultimately how to adapt to that. And what you see in this picture is just the interstate and the major roadway system. So starting to think about infrastructure, and then from a public health perspective, obviously that translates to evacuation routes and delivery of services. So an example of sort of how flooding infrastructure could be impacted. Now we've heard a bit about sea level rise, and we've heard about precipitation trends. This is a historic trend from 58 through 2007, showing increases in the amounts of heavy precipitation by percentage around the country. And I think what's telling about this is that the northeastern part of the United States, already a water-rich area in general, projected to get a lot wetter. You also see in the lower, in the southwest part of the country, there's expected to be a 9% increase in amounts of very heavy precipitation that might conflict in your mind with what you've heard about risks of increased drought. And so I just want to make the point that they're not mutually exclusive. You can have greater extremes in both directions simultaneously. Short, fast rains, which obviously, for reasons like this, cause major problems. And while Providence has made major strides in terms of combined sewer overflow remediation, if you will, it was during my undergraduate years at Brown that I first learned what a CSO was, and learned that many American cities built their sewer systems back when there wasn't so much impervious surfaces in cities, and so it didn't matter so much if you caught rainwater and mixed it with residential and household other wastewater. But if you aren't already familiar with CSOs, the general concept is that basically they quickly overwhelm the pipes that go to the treatment plants when there's greater than a certain amount of precipitation in a short period of time. In New York City, it's more than an inch in an hour. One of the earlier speakers said they got 3 inches in 45 minutes in Bristol a few weeks ago, I believe. That certainly would have overwhelmed our system, at which point we dump raw sewage into the Hudson or the East River or Narragansett Bay or anywhere that there's sewer outflow pipes. And that can mean lots of things for nutrients into the water, but it also obviously also means things like E. coli. So this picture is beach closing trends in New Jersey. And this is not to I don't want to falsely say that this is related to heavy precipitation events, because these beach closings over this period of approximately 15 years are not necessarily reflective of precipitation events, but they're reflective of an increasing awareness and perhaps increasing stringency of the surveillance industry, the public health department and the surveillance programs in knowing that it is a potential problem and either closing it based on what's red in this graph in terms of closed due to bacterial exceedance standards, or the larger bars or the yellow ones, which are precautionary closings. The upper Narragansett, correct me if I'm wrong, for 3 days after any heavy precipitation event, there's no swimming recommended there. That's just because they expect that there's overflow. And I read about other standing sort of precautions about Rhode Island beaches as well. So certainly, so we're talking about flooding or heavy precipitation, but we're also now starting to talk about infectious disease risk, right? Because the risk here is that people, recreational use of the water, will be exposed to pathogens that could lead to gastrointestinal illness or skin infections, for example. And here's another source of potential contamination. Looks benign enough, our bovine friends here. And I realize this isn't a major source of agriculture, type of agriculture in Rhode Island, but certainly other parts of the country. And this is relevant because this study that was actually based out of Canada, but with municipal water systems that are very similar to ours, showed that after a heavy precipitation event, so rainfall greater than 93rd percentile, they demonstrated a 2-fold increase in the odds of waterborne disease outbreak. And what's surprising about this is it's not in areas without municipal water systems. It's a contamination above and beyond, despite a robust water system. And this has been played out. This is one example of a number of studies that are showing correlations between both increasing temperature and increased diarrheal illness or gastrointestinal illness, and in this case, heavy precipitation events are the same. So a couple other examples of infectious disease links, and then we'll hear more about it in terms of vector-borne disease. This one is a map from the Natural Resources Defense Council, who put together a number of really, I think, helpful maps and sort of helping people understand the potential impacts. And this one looks at vulnerability in the U.S. between 1995 and 2000 to dengue fever. And in general, you can see it's mostly the southeastern part of the United States, and what the different color areas are Blue is sort of vulnerable to dengue fever infection. Red is specifically counties reporting positive for one or both dengue mosquito vector species. The gray was no vector mosquitoes reported, and then put the numbers, which are much fainter and harder to see, but basically to tell you that there were cases, suspected cases in every state, including Rhode Island, which I believe had 12 cases in the period of 95 to 2005. And even in my relatively short time being involved in thinking about changing niches for vectors and changing areas of prevalence of diseases, we previously really thought of dengue as a border disease, that it was happened south of us, but then that it was sort of on the Texas border, and so increasingly we're seeing it sort of come up from the south, spreading through the United States. West Nile, which we'll hear more about in Rhode Island specifically, this is just an example of, in New York State, for the positive test results looking at the mosquitoes specifically in 2008. Dark green is where there were other samples collected that weren't positive, and then the paler green or yellow color were no samples, so no surveillance was taking place. And so just an example to sort of get you thinking about distribution of vectors, but also to just make the point that it was in 1999 that West Nile was first detected, and then it was within less than a decade after that that it had spread to, I believe, every continental United States. Not a huge burden of disease, mostly affecting, again, as we talked about with heat, elderly population in terms of the severity of illness and their experiencing. And then I'll leave you with one infectious disease example for children. And this is Coxsackie virus. This is an editorial written by a pediatrician from Northern Virginia. Coxsackie virus causes hand, foot, and mouth disease. It's not a fatal illness. If you've had a child who's had it, you might have been miserable yourself because they probably wouldn't have eaten anything for a few days. And sometimes there's a risk of dehydration if you can't get them to really eat or drink anything. But it's mainly self-limited and just makes you miserable, and it's really painful to swallow. But pediatricians are typically taught that this is a warm season illness. And this editorial by this pediatrician was saying they had seen more cases in the first third, I believe, of 2011 than they had seen in the whole entirety of the previous year. So the point about climate change sort of changing seasons, as we heard with hardiness zones and herbaceous things, but also in terms of what's in pediatric textbooks and sort of our typical thinking about seasonality of diseases, and how that climate change might need to require that we rewrite some of those textbooks. So the last sort of case study I want to leave you with is ground level ozone, air quality in general, ozone, and then pollen. So the ground level ozone is not, so it's the ozone down here, our breathing level, not up in the stratosphere, and it's generally a respiratory irritant. And the reason it's most relevant to climate change is it's not emitted directly from the tailpipe. It's not what we call a primary pollutant, but instead it's a secondary pollutant. The pathway you see here is the process in which other molecules are converted in the presence of sunlight and warmth to create ozone, which is why you get high ozone days in the summer, the hot, sunny days. So this, as Sunshine alluded to, I've done a little bit of work in modeling what ozone will have effects going forward in the next couple of decades and how that would affect pediatric asthma. I'm not going to go into it in depth today for want of time, but I'm happy to talk to you more about that moving forward. We've looked at it for New York City and the surrounding area. The other air quality example is this, thinking about pollen, and this is specifically ragweed, and this is a colleague of ours, Lou Ziska, who works at the USDA. And he has done some really elegant work looking specifically at the carbon dioxide direct impacts on ragweed growth and pollen production, but then also looking at different latitudes and how the length of the season, of the ragweed season, has grown a lot more in the more northern latitudes. So some really interesting work. And that is leading to increased work in the allergy field and understanding of this multi-tiered pathway between human activities, carbon dioxide, temperature, these intermediate pathways that ultimately change the burden of allergies and asthma. And so, and put up here to go through the details of this flow chart, but just to make the point that research in climate and health focuses on multiple different steps, because we have to understand how each of these different arrows affect the subsequent sort of magnitude and direction of the change. Last couple points. That using extreme heat as an example, I already mentioned a number of vulnerability factors, but whenever we're thinking about the health effects, we have to think about things like comorbid conditions, whether or not certain racial groups, age, or educational groups, whether or not where you live has an impact, and then certain things like community geography. I mentioned urban heat island as witnessed as evidence in the lower right-hand graph there. All of these contribute to vulnerability factors and decide sort of who it's relevant to in terms of the specific exposure. This is the NRDC website again, and they have some Rhode Island specific information. And our last point here is that we can address other public health problems while preventing and preparing for climate change. And this is, I think, really key in what can often be a paralyzing message in what seems like nightmarish and overwhelming and really sort of beyond one's ability to deal with. So the examples I use and think about is helping people become aware that there are already air quality projections on airnow.gov that they can pay attention to if they have respiratory disease or their child has asthma, and becoming more aware of this sensitizes people to sort of the interconnectedness of these. Thinking about things like safe ways to manage mosquito populations instead of overreacting when we are faced with things like dengue or West Nile threatening us. Thinking about safe ways to stay hydrated during heat. Some of the interventions are so simple that they are often overlooked. Thinking about local foods and farmers markets and access to fruits and vegetables, which often in farmers markets have lower pesticide burdens and certainly can help affect people's diets in positive ways. Pedestrian-powered transportation in terms of addressing our obesity epidemic while simultaneously reducing our carbon footprint. And lastly, even for things like increasing rates of attention deficit, hyperactivity disorder, ADHD, we know that time outside and reduction of screen time have positive beneficial effects. And so there are links for me between almost every problem that's going to be made worse by climate change and solutions that we need for other public health